Hi, I'm Josh Irvin. I'm currently studying physiotherapy at the University of Brighton, and I'm here with Joe, who I'm currently on placement with. I'm in my last week of placement, so as a kind of final placement project, I'm giving a upper cervical instability presentation. And this kind of came around by, I was sat in on the HMSA live stream with Joe and Dr. Bull, and one of the things that came up was upper cervical instability, and which I found quite interesting. So I did a bit of research around it, and then I presented what I found to Joe, and she asked if I would be willing to do a presentation for service users. So we are now here. So upper cervical instability is defined as hypermobility of the cervical vertebrae and the craniocervical junction, which is often caused by laxity of the ligaments between the base of the skull and the cervical spine, or just between the vertebrae themselves. And this laxity often means that the spine is unable to maintain normal patterns of movement under physiological load, which can therefore lead to changes in posture, can lead to pain, and it can also lead to a number of neurological and musculoskeletal problems. So the joints where this instability occurs are at the atlanto-occipital joint, also known as the craniocervical junction, and this is where the base of the skull, so your occipital bone, meets your cervical spine, and this is called atlanto-occipital instability. And then also at the atlantoaxial joint, where your atlas and your axis, or your C1 and C2 vertebrae meet, and this is called atlantoaxial instability. And then there's a nice little picture on the right here of the vertebrae of the cervical spine from the Physiopedia webpage. The webpage has some great information on upper cervical instability, so you want to do further reading, there's a link to that in the references. So we're going to talk briefly about the anatomy of the C-spine. So the first one that we spoke about was the atlanto-occipital joint, and this is between C0 and C1. And it's the base of your skull, so your occipital bone articulating with your C1 vertebrae. And some of the ligaments involved in the stability of this, are the posterior atlanto-occipital ligament, the anterior atlanto-occipital ligament, and the movements that occur at this joint are flexion, extension, lateral flexion, and then rotation occurs in conjunction with lateral flexion. And the atlanto-occipital joint is responsible for about 33% of all flexion and extension within the cervical spine. And the other one we spoke about was the atlantoaxial joint. So it's C1 and C2 joints, so your atlas and your axis, and they articulate at the lateral and medial atlantoaxial joints. So again, some of the ligaments involved in this are the posterior atlantoaxial ligament, the anterior atlantoaxial ligament, the transverse ligament of the atlas, the alar ligaments, apical ligaments, and the tectorial membrane. And there's a nice picture on the right here, which is showing all those ligaments. The movements that occur at this joint are rotation, flexion, and extension. And this is where a majority of the rotation in the C-spine occurs. So 60% of cervical rotation comes from the atlantoaxial joint. So for this presentation, we're going to be focusing mainly on hypermobility and UCI, but UCI is often, well, is also seen in a number of different conditions. So people recovering from whiplash often get it just because of the strain and the trauma that's occurred to the ligaments. It's also seen in rheumatoid arthritis and also in Down syndrome. Studies show that around 6 to 27% of people with hypermobile EDS present with UCI, but this is only symptomatic UCI or diagnosed UCI. So it can still be present without the common symptoms, and it often doesn't become symptomatic until adulthood. So I think by increasing the awareness of UCI will hopefully help more people to kind of minimize the occurrence of symptoms if they're able to get comfortable with the things that you can do to manage or incorporate some of the conservative treatments into the management of your condition. It could greatly reduce the risk of this in later life. So there's a number of symptoms that come with UCI. This is just a list of a few of them. There's another list later on which covers them a lot more in depth, but we'll just pause on this slide a little bit to go over some of the symptoms. often with symptoms, what you're looking for is changes in symptoms or new onset of symptoms. So we'll cover that in a later slide. So this slide here is aimed more at physiotherapists and healthcare professionals to help them know what to look for when diagnosing, also when you should look to refer for further testing or for neurological assessment. So there's currently no gold standard for diagnosing UCI. And this flowchart on the left is from a study which is looking at ways to improve the diagnostic procedure of UCI. So as a healthcare professional, you'll often be looking at past medical histories, you'll be looking at clinical findings and observations, radiological findings, and neurological findings. So as a physiotherapist, there's a lot of clinical tests that you can do to try and help diagnose it. But with people with hypermobility, these tests are often a lot less accurate due to just the general laxity of connective tissue. And they can also be very, very triggering for the symptoms that come with it. But you can still do a good physical examination as a physiotherapist. So observation is a big one, just looking at posture when people walk in. With someone who has very severe, they may even be holding the chin as stability. You can also see the increased tone in the muscles in the back and back of the neck. Also the function, so increased range of motion, kind of beyond normal ranges. Also the sensorimotor tests, so eye movement, and also some of the neurological tests. So this is another kind of table of the symptoms. And it's broken into the MSK symptoms and the neurological symptoms. So you can see on the right as the highly suggestive ones, which is kind of likely to be caused by UCI. And like we said before, getting a timeline of your symptoms will allow you to notice the changes in the symptoms, so particularly in the neurological ones. So any changes you might notice over this time, have any current symptoms been getting worse, any new onset of symptoms, so with the lump in the throat under the neurological ones, I think it is, that is, so lump in the throat without the presence of a cold or illness. So Joe has an input for this slide.
I will just jump in briefly and say that these symptoms can also be caused by a range of other things. So before kind of assuming that if you're getting any of these symptoms, it's definitely some kind of cervical issue, it is worth considering whether this is a change in symptom, whether it's completely unrelated, or just basically having things investigated. So any kind of doubts whatsoever, check in with a healthcare professional and have something looked at, because any healthcare professional who isn't a complete idiot would much rather you got things checked than you sat at home worrying about something. So
yeah. So for management of UCI, there's a number of conservative management. So you've got postural education. I think patient education is great because it allows people to kind of take control of their treatment of their condition, which I think is very empowering for people. Strengthening exercises, improving proprioception, soft tissue mobilization, taping, again, patient education, like we already mentioned, and bracing. And then in more severe cases, surgery can be done, which is where conservative treatments aren't working. And this usually involves fusion of the between C0 to C2. So looking more at the conservative treatments for strengthening exercises, one of the bread and butter exercises for this are chin tucks. And this is to help strengthen the deep neck flexors. And these help massively with posture and keeping your head aligned above your spine. So to perform a chin tuck, there's a video at the bottom to perform it, but it's not tucking your chin down and under, it's tucking your chin kind of backwards. So you'd fix your eyes on a set spot and you can put your hand on your chin as a kind of marker, and then you're moving your chin back. I'll do a side view as well so you can see. And you would then hold that there for 5 seconds, sorry, and then move back into it. So a side view of it. You'll be seeing double chins when you do this, which is good. You want to get the double chins doing this. And if you want to add extra emphasis on the deep neck flexors, you can put a hand underneath the tucked chin. So then when you tuck, you put your hand underneath and you push down into your hand for extra resistance. Isometric exercise is also great for improving posture and postural awareness, and also proprioception and just neck strength in general. So these can be done standing up, sitting down. They're also quite good lying down. So very simple as well. You could just put your hand against the side of your head and apply a force, and you're just resisting that force. And it's nice because you can go as strong or as light as you need, and you can do it sides of the head, you can do it forehead and the back of your head as well. If this is too difficult, or maybe you have some issues with lifting your shoulders that high, you can do it lying down on your side. So if you lie on your side, you just lift your head up off the pillow, hold it there. So proprioceptive exercises. So proprioception is your perception awareness of your body in space. And through exercises, we're aiming to improve this awareness. So one of the big things with hypermobile people is that they get into very bad patterns of movement. So you want to be unlearning those patterns of movement, and you can do this by working out what your functional range of motion is, and find what the safe ranges of motion are and work out the functional ranges of motion. So you may be able to turn your head really far back, but in reality, do you need to turn it that far back? So thinking about the functional ranges of motion and then working within the safe movement patterns. So when you move your head sideways, go to the limit of the safe range of motion, and then if you need to turn more, you can then turn your body. So also for proprioception with posture, you can use kind of external aids such as K-tape, and this provides a bit of neurofeedback. So you would apply it's particularly useful for if someone is very kyphotic, so kind of the forward head. The head coming very far forwards, which puts a lot more strain on your neck. And by putting a strip of tape going down the back of your neck, kind of to between your shoulder blades, if you then come forwards, that will pull on the skin there and provide some external neurofeedback, which reminds you to kind of check your posture a little bit, which can be really good. Bracing as well. Bracing is, I think bracing is great for certain things. Bracing pretty much acts as an external muscular support. So essentially what it's doing is it's doing what your deep neck flexors do. So therefore, by doing the strengthening exercises to build up your deep neck flexors, this will diminish the need for a brace. As it's important not to become reliant on neck bracing, as it can lead to deconditioning of the muscles in your neck, which will then lead to a greater need and reliance for the brace. And there's kind of nowhere to go from a brace. So you could go soft brace to hard brace, but then from there, if you decondition too much, there's not really anywhere to go because you're so reliant on that brace. However, braces are great for certain things. So I think soft neck braces are great for activity splinting, for specific tasks and activities that pose a higher risk or have a lot of fear around them. So something like being a passenger in a moving vehicle and things that you don't have as much control over. It can also be great for management of neurological symptoms and giving you some relief from them. And also, we spoke about hard braces, which are also an option and provide a lot more support, but it's recommended to get them fitted by a professional so they're more comfortable and specific to you. This is the reference list of all the resources that I used. There's some great information out there for UCI stuff. So if you want to have a look through any of these, they're all linked here, and it's some great info. Yeah. I'm not sure if Jo had any OT specific input. I think she does.
I think you've covered pretty much all of it. Just Josh, thank you very, very much. For everyone watching this, what I will do is pop a link. We'll get the PowerPoint presentation put up on OneDrive, and I'll pop a link in so people can get the references off that, if that's all right with you.
Yeah.
Fabulous. Okay. Thank you very much. If everyone, if you found this useful, please do let us know. If you've got questions, feel free to ask. Josh will probably have left by the time we see the questions, but I will still be here. So if there's anything I can help with, please let me know. Worst case scenario, I'll just have to hunt Josh down and drag him back to answer them. So thank you all very much.
Thank you.
Cheers.